welcome other doctors from other hospitals as well. You're free to ask questions and interrupt the session and ask them. Shall we start? Oh, baru 10 orang ni. Okay Are we okay?
I'm okay because
Tunggulah 1 minit. Tunggu 1 minit lagi lah. 7:30 kita start.
Okay. Okay.
Last Friday, right?
Last Friday. This patient is 57 years old. Non-case of diabetes. Okay. Tunggu sekejap.
They're coming in. Start lah ni, Mani.
Okay, this patient is a 57-year-old man, no case of diabetes, with left eye white cataract. So initially the pupil was about constricted, so I injected intracameral adrenaline. Then after that it became this large. The CCC actually is a bit difficult because of the ASCC. Because part of it is macam fragile and part of it is too adhered to the intracortex. So I forward a little bit faster.
Kenapa suka inject vision blue dekat second port small wound? You haven't encountered the time when this vision blue gets into the different plane,
Okay.
And then you may end up having vision blue dalam pocket, the cement pocket.
Okay. Saya inject 2 kali vision blue because dia tak stain sangat. So saya put another injection of vision blue. Then after that baru saya proceed with the CCC. The video tu kat sini is not that clear sebab the video dekat microscope tu diorang tak adjust yang the focusing kat the video, the TV tu. So tak
accommodating ni, you accommodate kan? Dia tak adjust.
Bukan doktor, dia punya yang dia ada satu lagi yang focusing dekat TV tu kan doktor?
Betul lah, no, because you accommodate. Lepas tu dia blur. So what we normally do, we adjust the button to pergi dia adjusted. Meaning you're accommodating.
Oh, okay. Okay.
Kan ada button dekat mikroskop kan? Satu kan? Yang tu untuk adjust.
Sebab yang the next punya surgery tu pun blur juga. Tapi bila kita adjust the focusing knob tu baru dia clear yang dekat TV tu. Padahal yang the surgery clear.
Because you accommodate Mani. You accommodate, dia tengah stress ni.
Ni saya buat decompress. Tapi actually nothing come out. I start using the needle lah to make the initial flap. So saya lajukan sikit lah. Dia macam fragile, putus initially dan tu, tapi dia tak extend atau dia tak extend lah, dia macam melekat sangat dan susah nak tarik. So lama sikit lah dari sisi part ni. You can see yang part tu macam melekat sangat dekat the cortex.
Otherwise okay kan?
Yang awal-awal ni saya macam didn't expect anything at this point. Tapi lepas then saya proceed with the hydrodissection.
And surprise happen.
After hydrodissect, dia macam papillary snap sign tapi
Wah ni dah ada.
rupture.
Kenapa dia tiba-tiba snap ni?
Masa ni lepas saya tengok video baru saya rasa macam dia ada hydrorupture. Tapi the papillary snap sign ni macam usually saya selalu juga encounter masa ada uncomplicated cataract. Maksudnya suddenly the pupil get smaller after hydrodissect. Sebab saya dah few times encounter tapi tak ada apa-apa, so saya tak expect anything yet at this point. Tapi iris prolapse sikit dekat main wound. A bit difficult for me to.
Selalunya your other papillary snap sign, do you have the iris prolapse? Tak ada.
Tak ada. Kan tak kan? Lepas tu AC dia start shallowing at this point. Sebab kalau rain mesti jadi deep AC tu kan?
Taklah, nampak dah ni.
Nampak dah kat sini.
Mesti deep AC, tak semestinya.
Tak semestinya. It can happen with shallow AC pun boleh juga. Tu saya pun ada juga.
But fluid goes behind, right? Fluid goes behind. Tak semestinya semua masuk vitreous kan?
Okay. Maksudnya still lagi in the back. I mean the hydro.
What do other surgeon think? Kai ada dah ni, Khairudin ada kan? Ishak. What do you think?
Itulah saya tunjuk kat Ishak. Tak tahu Ishak dah online ke?
Apa soalannya tadi Aziz?
Macam snap sign dah. Snap. Snap sign. Masa dia hydro tu kan? Pupil suddenly small, lepas tu ada iris prolapse. Masa ni dah ada nampak macam snap. Itu obvious lah.
Yes, kalau you nampak snap tu, you kena be careful. Memang kena highly suspicious of something happen at the back. Tapi tak semestinya AC shallow ke AC deep ke, it doesn't shows that. Sebab awak AC shallow kenapa? Sebab iris awak dah prolapse.
Sebab semua dah leak through the main wound.
AC
Okay tu. Masa ni tu saya takut juga suprachoroidal ke apa, tapi patient not in pain, the eyeball is not hard, so saya tak expect suprachoroidal at this point.
Awak tak boleh jangan expect benda yang very serious complication yet. Jangan takutkan diri awak dulu. So proceed slowly, tengok dulu.
So
masa hydrodissect tu kan, normally I teach you to lift everything up kan.
Lift up
That's the word, lift everything up, lift your CCC, lift your wound kan. Jangan buat masa close wound. And then not too forceful. In fact, kalau dapat white cataract ni, you don't even need to hydrodissect.
Okay.
You just masuk ficul, lepas tu rotate kan dia. A lot of people, they don't do hydrodissection around.
Actually, kalau white cataract maksudnya kita macam boleh consider to do
you do gentle. Sometimes we never know, ada pola belakang tu, you never know. Kan? And satu lagi dia unnecessary sebab dia dah develop, dia tak lekat. Dia cortex tu semua dah jadi macam nucleus kan.
Dia macam anterior punya dah, sebab anterior tu sudah rasa macam lain dah anterior capsule ni sebab dia melekat. So kita expect posterior pun is about the same Doktor, macam tu.
Selalu macam tu.
Susah nak cakap macam tu Mahani. Jangan assume banyak sangat.
Lepas tu
Kalau white ni do gentle or don't do at all? Ni apa dia hydroresection?
masa ni saya baru je nak start.
Terus jatuh. Yes.
Dia dah sinking satu.
Ah.
So I cannot proceed. Saya tak tahu nak buat apa because kalau saya macam convert is even worse. I mean,
Apa convert even
Kenapa
worse?
convert worse?
Kenapa rasa
dia
worse?
dah,
Convert lah.
maksudnya
Buatlah bagus. It will be very safe control surgery.
Kena convert ni dah ni.
tapi masa ni Doktor, masa ni saya tak rasa apa-apa lagi. Lepas daripada ni baru saya je dah macam start thinking tu. Masa
But
ni
your fluid, you dah nampak dia sinking tapi your fluid tu push dia balik ke belakang tu tau. Worse lah. Jadi masuk ke belakang lah dia.
Sebenarnya saya awal-awal macam ni sudah sepatutnya convert to CE.
Convert dah. Jangan
Dr. Aziz, kenapa at this point kena convert tadi kan? Tak nampak apa signs untuk convert
dia
lagi.
cakap dah sinking. Dia cakap dah dapat sinking.
Masa ni tak obvious lagi Doktor. Dia lepas ni baru kat sini.
Belum,
tapi kan,
belum lagi.
Tapi kan when I see that kind of purple snap sign kan, memang nampak macam tu ni. Probably I will just convert terus right away. Dia convert jarang you dapat yang you cakap yang false.
Tu dah sengit.
Lepas tu kan Doktor, bila dah macam ni
dah jatuh belakang lah ni. Jangan kacau dah.
Doktor, kalau dah macam ni dia jangan kacau lah. Kiranya kalau nak buat
itu masuk bitrus.
Buat apa tu?
Saya inject visco.
Awak tolak lagi tulis dia.
Tak payah OVD.
Tak payah.
Tutup je. Tutup, dia dah jatuh. There's no point. Nanti banyak lagi bitrus masuk dan OVD masuk bitrus.
Okay. So actually
nak tanya boleh?
Nanti kejap. Kalau lah it doesn't sublux so bad, viscoelastic dia should go the other opposite side. Bukan the side yang dah banyak dislodge ni. Then you can push it to the center, then you boleh keluarkan. Awak tak perlu, this is a wrong way to selamatkan the situation. Sebab awak
tolak lagi ke belakang.
You push the nucleus lagi away from you. You should push the nucleus towards you.
Jatuh dah ni, tutup je.
Ada banyak sengit lah. Dari tadi, kalau tadi sikit tadi saya will stop. Immediately saya will stop. Saya letak viscoelastic maybe. Kalau dia not so much, dislocate dia tu kat bawah dia tu. Dan tolak tu.
bawah dia.
Bawah dia.
Okay, faham.
Awak tak tahulah.
Saya pun tak tahu nama apa lah.
Banyak sangat
banyaknya OVD.
Banyak lagi. Injek lagi tu. Aduh.
It doesn't do anything.
Takut I call dia.
Saya tak feel
Dia tak buat apa-apa dia. You close up and stitch. Kita ada VR services kan. Kena cakap dengan VR. Jangan kacau dah Petrus.
Cataract yang macam ni, kalau saya punya experience, awak dah rasa lain macam je from the beginning. It's not salah, it's not wrong or degrading to convert.
Betul.
Buat ECCE aja. Memang from the beginning you rasa ada zona lain. Sometimes tak ada pun. Then tapi at the end it's a safe surgery. That's the thing that matters. It doesn't matter whether you buat ECCE lebih ke atau FECO lebih. Okay? Very safe.
Okay, Doktor. So
kadang tak ada drop, tak ada PC rent pun kan.
Yes.
But you are still safe.
Tapi sebab awak kena ingat this is a dense nucleus. Sometimes dengan FECO awak yang terkial-kial tu boleh menerukkan lagi keadaan.
Okay.
Kalau begini awak rasa tak sedap, tak confident, tak apa. Doktor saya nak convert je. Tak apa.
Okay. So from the beginning lah, we have to
snap tu. Daripada snap tu.
Sebab you all still new, jangan rasa sometimes memanglah kita kena try, tapi kalau benda tu kita expect susah, ya jangan rasa malu nak convert. Jangan rasa you all ni tak pandai lah bila convert ni. Tak. At the end, kita kena ada safe surgery. Dan kita tak nak complication yang very bad after this. Yeah?
Someone wanted to ask question just now, siapa eh?
Sorry,
Orang
kacau.
Tak apa, saya Nazimah here. I want to ask doktor,
Nazimah,
ada tak
okay.
orang still buat posterior levitation? Ke dah tak
Well,
buat dah?
depends on
Surgeon lah kan.
yeah.
Surgeon. Posterior
Dia-
levitation yang cocok dekat pas plana dengan big needle tu depends juga kalau too far down.
Macam ni tak boleh. Kalau masa earlier on tu,
Yes, earlier on tu boleh lah. Good.
Kalau
Yang
you
cepat,
skill.
yang itu tak tahu lah.
You know
Okay.
sometimes what I do, kalau macam ni kan, kalau dah nampak macam snap sign apa semua tu kan, in order for me not to drop the nucleus kan, masa Fico tu kan, dah pegang pegang dengan Fico, pakai your dialer, tahan dari belakang. That one also can, but tapi you need skillful hand lah. Nak letakkan dia kat atas kan, then convert. And in order for you not to drop. Dengan Fico tu pun boleh, tapi you need a good hand, good
Steady hands.
foot pedal. Good foot
Okay.
pedal.
Alright. Okay, thank you.
Oh, okay doktor. Saya noted.
So, Stitch, apa jadi dengan OVD? OVD banyak
Lepas tu, vitreous still come up.
Vitreous ke OVD come out? Are you sure vitreous come out?
Vitreous. Lepas tu saya buat intravitrectomy.
Ayo, okay.
Aduh, buat intravitrectomy pula.
Sebab ada vitreous dekat
Are
manual
you sure
tu.
it's vitreous?
Ya
Oh,
ke?
OVD.
Banyak
Dia ke belakang tu.
Saya tunjuk ni.
Dia ke belakang mana ni? Dia probably vitreous tu tak keluar langsung sebab tak ada benda yang mengeluarkan dia kan.
Tak sempat dia nak keluar, udah tolak dengan viskolastik lah.
Okay. Lepas tu. Tapi saya buat intravitrectomy.
Kalau drop nucleus ni minimum intervention lah on our side, Mani. Nanti ada
Okay,
jadi banyak nanti kalau kita touch balik nak buat vitrectomy, ada PBD lah kan, semua tu kan. So we just keluar lagi, susah.
Okay.
OVD tinggal lah.
Masa ni.
OVD tinggal dalam.
Sekejap saya tak ingat saya buat apa lah. Saya buat intravitrect. Lepas tu
Ni awak dah buat kerja sebab awak dah letak suture ni.
lepas
buat lah.
tu baru saya
Lepas tu baru boleh fikir. Ke apa?
tak. Saya dah buat
Mani, dia it works like this Mani. Bila dia drop kan, tak ada vitreous tak sempat keluar dah. Drop nucleus tu je. Jangan kacau dah. Jangan bagi vitreous tu keluar. Then you stitch it up. Just make sure there's no vitreous at the wound. Itu je. Lepas tu kita call VR surgeon lah. Jangan kacau vitreous banyak sangat. Nanti banyak jadi inflammation apa semua kan.
Doktor, kalau macam saya tak convert ini, kalau lah saya tak convert ini, lepas sebab benda ni masa yang hydrodissection tu baru saya notice dia dia pupillary snap sign tu. Apa je saya cakap? Tak tanya. Lepas pupillary snap, lepas tu saya nak kena convert macam lepas tu nak dilate pupillary jadi kecil, itu saya kena masuk iris hook semua lah doktor kan?
Iris hook untuk you tak kena dapat deliver. You kena scoop je. Kalau jadi you mean kalau nucleus to sinking, for snap sign nucleus sinking, snap sign dulu, dia tak sink dulu tau.
Dia snap sign dulu.
If I were you, I would just convert.
Masa pupillary snap sign tu.
Dia masa tu boleh sempat lagi sebab dia tak sinking pasal kan.
Tapi masa tu dia kecil sangat, so saya masuk kat sini. So
Mana nak tengok snap sign tu?
Yang ni jap
Tunjuk balik. We learn from this video.
Sini kat sini.
Sebelum lagi sikit. Okay. Try.
Lepas ni kata dia dah complete CCC. This point.
Jarang
is it-
kita dapat normal hydrodissection macam ni. Kan?
Okay. Okay, Dr.
Mahani,
Yes, Dr. Suci.
just wondering, before you hydrodissected, did you remove any OVD? Because I saw when the snap sign occurred, there's so much OVD coming. Because in this case, your CCC is very small. So when you hydrodissected, the fluid had nowhere to go because of the OVD in the AC. I know routinely we don't really remove, a lot of people don't routinely remove OVD. But in this case, I think because the CCC is very small, and I think because you anticipated a wide cataract, I'm sure your AC was very deep
Yeah,
and
I
full of
removed
OVD,
it.
right?
Kat sini I
You
remove
remove.
a little bit. Then
Okay.
I press a bit at the coastal lid.
Okay. Because you see the amount of OVD that came out.
Still a lot.
So I think it's a posterior rupture because the pressure in the eye itself was very high.
Mhm. Yeah, I think so too. At this point, after the surgery. Okay.
The forceful Mani, forceful push, is it?
Forceful push during the
Hydrodissection.
hydrodissection. Tak ada rasa sangat. I mean, I feel like it's
Depends.
normal.
Something fragile, we don't know.
Just a fragile cataract. Apa soalan awak tadi, Mani?
Tak ada kat sini kan kalau saya nak convert.
Tadi, ha.
Pupil dah small. Lepas tu
It's not small.
Boleh je
Okay.
kau
Not
Mani.
small.
Dia akan keluar Mani. It will come out.
okay.
Awak kena buat banyak ECCE. Lagi.
Okay,
Even the pupil is smaller than this, if you want to do ECCE and extract the nucleus out, you boleh manipulate and keluarkan the nucleus from the small pupil.
Big
Boleh.
wound lah.
Boleh lah. Saya tak convert.
Buat wound dia besar.
Sebab
Big
kalau
wound.
wound dia besar. Wound
Okay.
besar tu kita boleh manipulate, sengetkan the nucleus ke kiri ke kanan, it will come out. Sebab iris tu kan flexible, dia boleh membesar. Melainkan kalau ada PS lah, itu susah lah. Kalau iris biasa, even the pupil is small, sebenarnya you can manipulate, keluarkan a big nucleus.
Okay.
Jangan takut.
Right, we learn lesson lah.
Okay, the lesson learned.
But it's actually very clear snap kan. So we never forget this lah Mani. Kalau once you get it, you never forget.
Okay, Doktor.
Alright, ada lagi guys? Yang ni okay kan? VR dah buat dah.
Lepas tu Dr. Hafiz continue with the
So apa dalam tu memang PCRN lah. Memang
yes, PCRN and masa yang awal-awal tu dia just hanging dekat temporal side, tapi masa dia dapat kat Dr. Hafiz tu it's already dropped, and then Dr. Hafiz did the phaco fragmentation and the lens was put in the sulcus lah. Then after that the vision, I think latest there's a epithelial defect but the vision still counting finger, but treating the epithelial defect first, hopefully the vision gets better. Otherwise the fundus looks just moderate and mild NPDR. The macula looks flat.
Right.
I think following up the patient because still epithelial defect still quite large lah.
Okay.
The corneal epithelial defect.
I think the capsule fragile ni belakang, depan belakang.
Okay, tu.
Not your fault lah, right? Okay. It happens lah. But manage complication well.
Yeay, satu drop untuk Mani.
Okay.
Semua orang ada drop. Jangan risau.
Semua orang ada drop, betul.
Okay, tu.
Next.
For me, I think lepas ni Stella nak present.
Okay. Right.
Stop.
Stop share.
Good morning, Dr. Aziz, Dr. Harry.
Yes, morning.
My case is not really a complicated cataract, it's just difficult. The video that I have is only about difficult sub-incisional removal of cortical matter.
This one also done in OT1 ni. Semua OT1 ni. So we get a better recording.
Yeah, mine one OT1.
on dulu baru share. Okay.
Can see my video. Hello?
Boleh. Can.
Can see. This is a 58 years old Malay gentleman with underlying diabetes hypertension. Otherwise, the cataract was NS 2 plus with early PSCC and cortical cataract. I
Or
first
accommodate kan. Tidak as clear as what we expect.
stress.
Semua accommodate mula-mula. Okay.
And after incisional and
Vision blue.
and then proceed with CCC.
What's your worry if you're not using vision blue, Stella?
Because there's one time I experienced not using vision blue, that was my first time. Once I'm trying to do my flap to elevate the flap, suddenly the cortex all came out and blurred that flap, and I couldn't find the flap because I was not using.
Because you kacau cortex kan.
So that was my first experience. So dah takut tak dapat identify my flap. Then when trying to catching the flap again and again, and it became like extend far periphery. So
Don't make it a routine. So
Okay.
kalau clear cataract, very good high resolution microscope, you'll be able to see. So you have to improve on the way you create the first flap lah. Kan? You're not supposed to disturb the cortex.
Kalau you tak nampak on that side, pergi the other side, pergi side yang lain, create a new flap. You tak boleh keep going and using vision blue ni. Okay?
Okay, Dr. So,
Banyak striae kan. Remember that day I told you, Stella, right? When you see striae, meaning the way you hold your forceps is wrong, you have to reposition kan. Actually, buat the pivoting. Don't drag your wound. Oh, if you drag your wound, you see the striae.
Hydrodissection. Remove a bit of viscoelastic.
Tengok drag kan, drag wound. You're dragging your wound with your cannula.
I was clearing the cortex initially, and then do my sculpting.
Not many people in OT to notice that you accommodate kan, betul tak, Stella? Selalunya kalau we have many people around, those who watch the video will tell you you're accommodating or they adjust the button lah. Tapi kalau tak ada orang dalam OT, tak boleh notice lah.
I'm like making the groove deeper and wider. this part all I fast forward sikit sebab nak
Correct.
after remove the heminucleus, then the other side, then
Waalaikumsalam just kepada korang.
Straightforward kan?
sure. Lepas tu nak remove cortical matter ni dia especially the subincisional tu dia catch the back many times, so show that the cortex was really adherent to the posterior capsule. So when I was like pulling it out itself, it's actually bringing the back together with the cortex up. This part also can see that cortex is like really adherent and the back was actually lifted up when one remove it.
So what do you think is the cause of it?
Hydrodissection time, is it, doctor?
Oh, it's not properly hydrodissected. Normally we to avoid you dragging the back end. Normally we don't pull it like physical pull it. You press actually instead you press your foot pedal so that the vacuum suck it. The vacuum is pulling it rather than you're pulling out. Okay, looks okay.
This part came, there's another small part left actually. This part. So quite struggling. The back is actually coming together and pulling, so I leave it. Then I change my probe the other side, rotate it to catch that the cortical matter again. And
Kamu tak pusing belakang terus, why do you need to see that hole?
terus pusing belakang.
Yalah, can someone explain? Siapa ada kat sini? Cindy ada? Cindy?
That's catching the back again.
Cindy, sama?
Yes, Doctor.
Can you explain? Can you explain the maneuver kan, like this and you need to see the hole. What do you catch? You catch the edge of it then?
Yeah, actually
Catch the edge of it.
I understand Stella's worry because that is my problem also. Every time when I clean the sub-incisional, although Dr. Ida always say, don't worry, just look at the PC. It is a blind procedure kan by right. But takut juga.
When you see the hole, you tend to catch the edge and the PC. But why can't you just push, turn it
all the way back kan?
And make sure your irrigation is in, and that's it. Settle.
Yeah, I think theoretically it sounds
What can
you
catch?
Of the PC is behind and there's nothing there already.
Okay. I ask you a question. When you push it down totally behind kan, fully irrigation and fully irrigated eye, the PC is pushed down. What can you catch?
True,
you will not be catching PC. You will not be catching CCC. You'll be catching the loose structure, which is the cortex.
Yeah, understand that. Okay.
Stella, you remember I nak ambil subincisional cortex last time yang kita buat phaco and that combine amak valve?
Yes.
How many times did I catch the PC, the entry capsule? Many times. That's why you kena control your kaki. You will tend to catch the capsule tu. Tapi that's how you do it. Bila catch you lepas, then you kena push the probe bawah sikit lah. Memang macam tu. You kena belajar berani.
Okay, macam I think because more takut is actually we might make it something worse
If you caught the entry capsule pun tak apa. Cuba masa you buat di subincisional aspiration cortex removal ni, you kena do it slowly. Then you kena nampak clearly. When you caught the entry capsule kena lepas. When you caught the PC kena lepas. Eventually it will come out. It will come out lah kan.
Tapi I tried macam dah 3-4 kali catch the bag tu, I dah takut dah. So I try
3-4 kali tak cukup. 3-4 kali tak cukup. You tengok how many times I try hari tu. Banyak kan? Okay, tak apalah. You masuk lens then you can remove.
Then I try to rotate.
Koa avansi Koa kan? Betul?
Bukan koa tu.
Like that
Okay.
Sebab nampak haptik panjang ni.
Aziz,
Aziz, yeah.
what is your opinion? Because I was previously taught that if you assume that the submission is difficult, better remove it first with the partial support of cortex or soft lens matter.
We normally do it.
Rather than do it last when you don't have that kind of support.
I've been teaching them to do first. Simply because of that reason, and the other reason is because they tend to hydrate the stroma, then towards the end tak ada view. So, and it's actually easier to remove it first. You will engage and drag it down 2 ways kan, right and left. It's actually easier. With our very good microscope, very good machine nowadays, it's good to do that.
I will next time try to remove the substantial first.
Tapi there are disadvantage kalau you remove dulu. If you clear the other side first and you do it last, the subincisional cortex, if you have any problem, PC rank ke apa ke, at least the rest of the area is clear. You faham? That's why people sometimes do it last. Because if complication happen, at least the rest of the area tu dah clear. That's the setback kalau you buat this thing earlier. And kalau you have problem, banyak, when you do this submissional, you trying to get it out and you have problem, and the rest of the area tu, the cortex is still not removed. Susah lah pula you nak remove that thing kan, sebab mana tahu because dah keluar everything kat situ. That's the reason orang buat last.
So how to remove this? Hari tu nampak siapa buat? How to remove this below the IOL? Siapa nak tanya? Salma, mana Salma?
Dr. Aziz, can we change to J-probe?
What is J-probe? J-probe. Ada ke kita? Boleh. Tapi what's the difference? Kalau orang buat by manual kan, ni senang je buang. But what else can you do? You have IOL in. Is below IOL, what can you do?
Because already we actually trying to remove, right? So the anterior capsule dia punya cortex dah tak ada. It's already all below the IOL, so also difficult to remove.
Dial lah, letak viscoelastic, dial IOL. The whatever kan haptic dia kan. The cortex will come out. Hari tu suruh siapa buat? Amira kan? Mana Amira? What do you think, Amira? Tak ada Amira dah. Tapi nak kena letak viscoelastic balik dalam. Kalau significantly besar kan, left below the IOL, kena letak balik viscoelastic.
Betul.
Hari tu keluarkan Amira? Keluar kan? Okay.
Hari tu saya ingat nak tinggalkan je. So memang lash of the cortex kat sub-incision tu, I insert back the viscoelastic at the back and then rotate the IOL. After
dia keluar kan? Hari tu keluar kan?
Memang kena rotate betul-betul lah.
Ada way lah. Don't leave all this. Jangan practice tinggalkan dalam tu. Let it clean. Be very clean.
Okay, Dr. Aziz.
Dah, Amira. Okay kan? So far you okay, Stella? You improve?
Yes, I improve my way of doing it. Like the vision blue all, I don't inject through the side port already.
Make sure you all improve every time you do. Just
make sure you dapat rotate. The problem with you rotation of the nucleus, you still weak hari tu. Okay.
Thank you, Dr. I have. That's
Next.
all.
Ada lain?
Tak ada. For me, tak ada.
Tak ada patient dah? Anything else? Takkan dua patient dah? Present je lah apa-apa, Stella. Any cases that you have? Mani? You've been recording, isn't it? Tak ada dah? Present je apa-apa.
Tak ada dah.
Question. Before that kan, I just want to ask yang junior ni, our junior surgeon, siapa nak tanya? Orang lain semua tak buat lagi. Salmah, Cindy lah tanya. Cindy, what's the purpose of us when we do divide conquer kan, divide conquer chopping kan? What is the purpose of doing those? I mean, we have developed the technique to divide conquer into 4 segments. When you also chop, you chop into 4 segments in the back, kan? In the back, kan? What is the purpose? This is a very basic question.
So that we are able to remove the nucleus without inducing too much stress on the zonules, is it, Doctor?
Correct. The smaller the better, kan? Because you don't want the segment to touch the CCC or to touch the PC, kan? So you can remove it through the CCC that you have and remove it safely. You shouldn't be doing chop and tumble it. Let's say a big nucleus, kan? You hold the nucleus and you go to the periphery using your chopper and tumble. Tumble meaning tumble. Can you imagine the diameter of the nucleus when it's tumble? What can it do to the CCC? I mean,
it will stretch it and.
I was upset. I saw a surgeon doing it. It will stretch the CCC, it will stretch the PC, it will stretch the zonule. And
understand.
You can get everything there. You can get your CCC tear because the CCC is that small, but your diameter of your nucleus is so big, you stretch the CCC, it can tear. When it go up vertical like that, it can stretch your PC can open up. During manipulation, when you try to chop at that position, you can induce zonolysis. And please don't do this. This is very basic. That's why we do divide conquer. That's why we do chop mostly in the back. We don't lift it up. We crack smaller in the back before you remove through the CCC. Remember this. This is your very basic. Remember, you bring this forever in your career. Okay? So the cost for zonolysis is that. Okay?
Yeah, understand, Doctor.
You just look for the videos. I've sent it to you. Okay.
Yeah, already saw it. Understand.
Ada video. Mani?
Saya dah tak ada video dah, Doktor.
Tak ada. Terus saya prepare sekejap ni. 8:13 baru. Lagi? Lain? Sini prepare.
Okay lah, Doktor. Sekejap ya. Sebab
you present, okay. Just one video and then that's it. Okay.
Stella, tadi waktu you sini kotak.
Orang on tu lain, tempat lain.
And then actually you can push a bit of the IOL away. Then you can test the cortex easily.
Mahani dapat buat berapa kes for the past 1 week?
Last week, Doktor.
Sampai today.
Sampai today.
In a week last week.
4 kot.
4.
Maintain 4 lah, 3-4 dapat.
3-4 lah, lebih okey.
Stella?
Ya, buat 3 sampai 4 lah.
Maintain. If you all do less, you have to let us know. Dia kena bagi chance, more chance. Habis gazette nanti bekerja nak dapat number.
Okay, Dr. Aziz can see my screen.
Can.
Okay. So this is a case I did yesterday with Dr. Ida. It's a 65-year-old lady with underlying hypertension. We did a left eye echo for her for left eye white cataract. Presenting vision was counting finger 3 feet with axial length of 22.39, and the IOL we implanted was an Endista plus 22.5. So the initial part until the hydrodissection, Dr. Ida did. So I will forward first, yeah, later.
My experience kalau buat white cataract ni,
Ya, betul.
anything can happen. You have to be very careful and pay 100% concentration.
Yeah.
PC to everything sebab capsule is fragile.
Betul. And then this patient initially, actually, she was very anxious. Mata dia gerak banyak. So we actually gave subtenon. And then ada subconscious hemorrhage because had to stabilize the eye when doing the CCC because she have a lot of like sudden movement.
Apa. Banyak subcon hemorrhage pun tak apa as long as the surgery went well.
So after that, yeah, so from here, I'm doing scalp already, and then now trying to crack into the heminucleus. But
Sekejap sini.
yeah, betul.
Stop. Yeah.
Okay.
To give you a description just now, when I told you all the tumbling in. So this, let's say this is white cataract. So the person will just hold the hole inside the groove, or no grooving at all, just masuk dalam, and the chopper goes to the equator and lift it up. Lift the lens, the nucleus, jadi vertical tau. Nothing, not chop at all, nothing. It's a big lump or nucleus like that, coming out of the back and chop just like that. That is totally wrong. You shouldn't be doing that. So that's why we do chop in the back like this, or divide conquer in the back, so to make the segment smaller. Okay, go ahead. Sorry, Gacha.
Tak apa. So my problem was chopping lah, basically, doctor. Although this cataract actually was the better one that yesterday, not too like a lot of strands or anything, but when I chop, I only managed to chop actually the cortex area, not the central nucleus part. So when I chop, I can see that actually the center nucleus was still intact. So I think because of that, later throughout the whole surgery also, I was like, a bit difficult lah, because of the central bulk was not cracked fully. So
rehold deeper lah.
So because then actually Dr. Ida also got tell me to sculpt the central nucleus and then try to just divide it lah.
And it's all about the nucleus.
It's all the nucleus. So then because I have experience where when I was trying to chop, then also induce zonulysis. So after that, I was quite traumatized. And whenever trying to chop also in like white cataract and the more dense one, I'm a bit scared that I cause a lot of stress on the zonules when I'm chopping.
This one
like where I tend to push down lah.
You don't have enough nucleus to hold.
Actually ada, but my problem I think was actually I wasn't holding deep enough lah.
Betul.
Tak dalam.
Tak
the center
cukup
part
dalam.
je yang I think keras sikit for you to hold. The rest at the periphery tu nampak macam soft.
Tapi yang ni sebab dia dapat chop just at the center tu, can see the bulat punya nucleus tu intact. Dia just the tepi-tepi part start to be
the center tu yang liat sikit.
So the center like remain not fully separated. That's why throughout the whole surgery tu macam lambat juga because like the center tu terlekat kan, so I have problem like removing the segment by segment.
How to prevent this?
Doctor, I think maybe my sculpting also was not deep enough. So I felt like I have went like deep enough, but then I think tak cukup lah. So when I start to chop, actually only the superficial part is cracked, but then the nucleus was still intact. Yeah, the bottom is not full, so I struggled a bit to remove the nucleus. Yeah.
Well, you started from beginning, and that's improvement. Kan?
Yeah. Yes. So
Started from the shop, the
now
group. Okay.
starting from sculpting. Yeah.
Okay, that's good.
So yeah, because I think sometimes I get that instead of just grooving and all, I tend to use the probe to press down on the nucleus. So I think that is something I still need to practice so that I know to gauge how much pressure lah. Yeah, and not stress the zonules. So for this case, actually, because of the not full separation of the central part of the nucleus, then the nucleus removal was a bit challenging yesterday for me.
You know how to do this, and you hold one segment, and you manipulate with your dialer the other segment. Dia akan putus. Kalau yang
Bawah
center tak,
sikit yang ada.
you hold this segment, and you manipulate the other one.
The second
Because your second instrument tu tak jalan. Selalunya boleh. You just need to do more.
Okay. Yeah. True. So, but then otherwise, because towards the last segment already, so I lagi takut sebab I can see behind there is not much cortex left already. So when very slow and then takut like tertangkap PC.
What's the difference if there a lot of cortex behind?
I feel macam ada benda dekat belakang tahan my PC.
It's in your head only lah.
Yang ni I nampak like, the red reflex so clear already, dah start takut dah. And then it's because now all the fragments is like so small and like takut dia suddenly just enter into the probe and then the PC terus datang.
Well, it's good to see PC, right? But PC is okay, kan? It's good to see.
This one PC okay because then left that few fragments at the side here. I just use the IA probe to remove. So otherwise lens managed to insert in the back uncomplicated lah subsequent for this surgery later.
You improve, I think. And
I think a bit more comfortable slightly.
You press more phaco now.
Yeah. Tapi I realize actually my phaco power is still dalam berbelas saja. So maybe next time I think the pedal have to betul. Because this one a bit keras already, kalau tak press dia tak masuk langsung.
Good.
Tapi lah. I think my pedal I need to berani and go down a bit kot because I noticed the phaco power actually is only about like 15, 16 when it naik lah. Tak naik sangat pun. Okay. So after that for the cortex, I think I have same problem like Stella also. I usually only there to clear those that I can see. And for sub-incisional, I tend to struggle a bit also.
You know, last time we have a video recorded. I don't know where it is now. When we actually tried to look sub-incisional removal, right? When you actually try to look at the hole, you're actually looking hard for the hole to be visible. And what happened to the sleeve? It gets king. King. Because because it's a not natural position because you're trying to look hard for that hole. And what happened is if you press, you get aspiration and vacuum, but you don't have irrigation. That's why the PC come up. So I have a video. I have to search for the video.
Okay.
Because that's why we advise terus ke belakang because it doesn't king.
Itulah, I think when I still feel like safe. Need to see everything to feel like safe. So I understand the concept. So we'll try.
You take time. But as long as you're comfortable, no tremor, I think you're comfortable doing it. So you just need
Yeah. Itulah, have to be more berani sikit lah. I understand. Okay. Yeah. So dah. This one actually the sub-incisional came out lah after.
Automatically without know.
Yeah. No, like tarik sikit dia dah keluar, so nasib lah. Yeah.
Doing it by manual IA is much easier, but we don't have that equipment. And
Yeah.
some people they don't like it also because of extra wound. But it's quite fast. You can remove some incisional, you can remove OBD under
Yes, betul. Saya dapat buat one or twice by manual lah. Masa tu ada dia orang pinjamkan kita pro. Memang best.
very efficient.
Okay.
But that doesn't mean coaxial tak boleh buat. So tengoklah kalau kita ada duit kita beli dapat extra wound lah, we'll see.
Okay. So the actually otherwise no.
Sorry, Doctor, I just stay lagi. Just wanna ask. So the sub-incisional, what you mean is that whole we straight away 90 degrees turn backward, and we don't need to visualize the whole lah. Terus nak pergi ambil that.
I normally don't. I teach you all like our registrars and they don't, because they just go direct behind and play with the segment.
Dia nak bagi.
They will come out.
Tapi dah.
Think about it, Stella. Think about it. If you go behind and it's fully irrigated eye. The eye is fully irrigated. The PC is pushed down. The system is compromised. What else can go into the probe? The loose segment.
Yeah.
Tengok kalau I guna teknik tu lah.
Tapi your probe must be deep enough. Kalau you tak deep enough, bang kita.
You make sure irrigation tu masuk.
Yes.
Tak, dah share ni.
Apa ni?
Tak. Sorry.
Tapi tadi juga ke?
Yang tadi punya dah lah doktor. Because after that just masuk lens je, tak ada problem sangat.
Alright. Ini saya Ida buat ni. Ini okey kan?
Ya. Ni Dr. Ida punya. Tak. Actually Dr. Ida nak tengok, I tak perasan yang dia terus share.
Ida nak kita orang komen ke?
Ida tengok kan?
Boleh juga.
Buat stand ni.
Buat stand.
Yang bahagian cortex tu.
Cortex.
Ni on kan?
Ni on. Ni mute ke? Tak.
Doctor, actually I'm having difficulty in removing the cortex because I think first time I saw the cortex macam satu sheet of paper. Kalau saya tak remove tu saya tak perasan sebenarnya ada satu layer cortex. So I was like, tak tahulah, I was bold enough ke. Sometimes I say, is it bold?
Small picture kan, tak nampak edge kan. Kita nampak edge.
Tak, macam sangat clear. Then I realise, ada lagi. Yang ni macam dia punya layer of epinucleus. Sekejap, cepatkan sikit. Okay, after this. Yang that part, sebenarnya kalau saya tak peel, then saya tak perasan sebenarnya ada cortex lagi dekat visual axis tu. So I have to like slowly peel off from the PC. Ini still the cortex and epinucleus. I think the next one good.
What else can you do with that?
Saya nak tembak pakai air, tapi sebab dia punya PC tu sangat fragile, saya takut nanti terus jadi lubang. That one tu dekat tengah, dekat in the middle. I was trying to polish, kata besarnya dia punya, is like one sheet of cortex. So I have to really peel off sebab saya nak tinggalkan dekat visual axis kan. Any other tips tu selain saya polish?
Tembak tu tak jalan. Tembak dengan basis.
I tak try sebab dia, I don't dare to try because the PC is really fragile, and then asyik bertakung dia punya eye. He has deep seated eye.
Kalau I ni the PC is strong, it's not fragile. Apa ni? Iris retractor semua it survive, it's strong Ida. Cuma you tolak dengan tip of the viscoelastic punya Rycroft tu. Sambil tu inject viscoelastic, you quitkan dia dengan tip of the Rycroft tu. Boleh.
So saya rasa macam dah tangkap PC sikit. Kita
Tak ada lah, boleh.
kejang tangan untuk buang dia punya tu je semalam.
Ini at the periphery kan? One shift tu lagi kan? In this video ini.
Tadi dekat betul-betul tengah-tengah doktor, at the posterior capsule. So I have to peel it off towards the periphery.
Ni dah peel lah ni, peeling lah ni.
Tapi saya rasa periphery tu tak habis. Saya dah tak berani sebab tak nampak.
Tak nampak kenapa?
Pupil small.
Pupil punya besar gajah ni dia kata small. Dah tarik bagai nak rak ni dia kata small. Allahu Akbar.
Dah besar.
Besar ni ha.
Stres. Macam tak nak tanggal kenapa dah sticky banyak.
It happens lah. Sometimes we get all this.
Yeah.
Dalam remove sikit-sikit. Selalunya dia akan
memang
hydrated.
kena buat. Tapi you have to remove it totally. Tapi lambat lah buat.
Memang
at times bila you buat difficult case macam ni, you rasa nak stop. You rasa nak stop. I've been there. You rasa nak stop bila nak habis. Tapi tak boleh. We're thinking about post-operative complication, post-operative
nanti memang opek terus.
Banyak patient will not get a good vision because the thing that we have done. So you kena buat juga Ida.
Okay.
Ida, the purpose of shooting tu kan, dia bukan nak peel saja tu, dia nak hydrate kan. When they get hydrated, you just peel off.
Dia kembang dan senang you catch.
Dia bukan push, bukan tembak untuk peeling dia.
Sudah, dia takkan
tembak bagi dah hydrate.
Akan go off kalau you tembak je. Tapi kita nak ada edge yang kita boleh catch.
So sticky.
It happens.
Okay. Actually saya nak tengok yang bahagian side incisional tu. Kalau ada yang macam doktor cakap tu, saya nak tunjuk kat Stella. That one.
Saya rasa masa awak buat ni vacuum awak tak kuat.
Saya tukar
awak tukar ke mana?
Polish. Saya tukar polish.
Kenapa tukar polish?
Kenapa tukar polish? Polish slow. You kena buat. You kena normal. IA tu, power tu, aspiration, vacuum.
Control dengan foot pedal lah. Jangan tukar polish.
That's why you sambat. You control with your foot. Tetap tak ada setting IA, you control with your foot.
Ayo, dia kan dah sebelah ada complication. Yang ni yang saya nak tunjuk kat Stella sebenarnya, yang tak payah tengok lubang.
Boleh? Nampak?
Kita memang tak tengok
dia ballooning.
Memang tak tengok lubang. Kita tahu lubang tu ada kat situ.
But it's quite difficult so because it's very very sticky.
Sebab float ni, pooling water ni, you don't have view kan?
Yes, tapi memang this is the problem bila you pakai iris hook. Sometimes you punya CCC jadi eccentric. Kan? Memang buat slowly.
Kalau boleh saya tak nak pakai iris hook tu, tapi saya tak maulah nanti ada complication susah. Dia sudut expression ni.
Kalau boleh kita tak nak buat surgery pun sebab kita tak.
Aduh.
Tengok PC dia tak tangkap because irrigation port semua masuk, the eye is fully irrigated.
I make sure that the irrigation port tu nampak dekat betul-betul dekat sebelah the aspiration punya lubang tu. Tapi kena macam banyak main tarik tali lah because it's like so sticky. Yang penting for the junior tu the pedal control lah, sebab kena control the vacuum tu, jangan kalau dah tertangkap PC boleh terus off the vacuum. And then the lubang tu bring up whenever macam dah tangkap tu, the lubang tu bring up, jangan bagi dekat tepi je, if not it will catch PC other side.
Okay, thanks Kak Ida.
Bukan dia pooling tu pasal conjunctival ballooning?
Ya, conjunctival ballooning pun and then patient tu dia memang deep socket eye. So banyaklah problem ni patient tu. Sometimes I feel that I want to do clear corner incision sebab limbo incision selalu balloon.
Okay dia tu.
Okay. Akhirnya.
So your surgery time berapa lama you buat kes ni?
Alamak, tak pasal berapa time. Sekejap doktor saya tengok.
Ni dalam 1 hour hari tu.
1 hour?
Sekejap, sebab ni dah
1 hour?
Saya bagi Cindy buat ni juga, apa namanya?
Untuk
insert the apa tu, iris hook. Nak bagi dia merasa buat.
Oh, Shinji yang insert.
tak, saya insert satu je.
Dia insert yang
Satu
last
kaki.
one lah. And then remove the last one.
Tengok bagi dia.
Dia tak pernah buat lagi. And then I forgot I already remove the visco. Kata alamak, dah remove visco, kenapa tak buat? 45 minutes betul. 45 minutes.
Okay.
And then I remove the visco first without removing the iris hook. Then ayo, kena letak visco balik.
Teknik ni stress.
Yeah, stress.
Okay.
Thank you for the tip.
8:35. Any other thing that you want to bring up? Any questions from the floor? From the audience? Huda, Razia, senyap ni. Ada komen apa?
Tak ada, Doktor.
So siapa yang dah drop nucleus ni? Dah dapat medal? Huda? Mani? Yang semalam yang you discuss about 4 drop nucleus tu kita punya kan? NED tu.
Betul. Yang previous, I don't know
Masa
which
NED tu
month.
kita punya
Kita punya. From January to
January
Jadi 5 lah. Jadi 5.
Kita punya trainee lah tu. Kita punya trainee lah kan?
I think so.
Okay.
Alright, 8:36 Shall we end this? Anything else? Ada apa-apa lain? Sini, Salma semua tak ada? So we will meet up in 2 weeks time.
Okay, Doktor.
I will share this.
Thank you everybody. Good job.
Yeah, thank you.
Okay, thank you, Doktor.